Okay. The first question, and maybe is the first question behind the table, or?
Yeah, so I appreciate Dr. Bach's thoughtful comment about the importance of peak cough flow. And
the microphone, yeah?
Closer.
Okay. I appreciate Dr. Bach's thoughtful comment regarding the importance of peak cough flow. And that's certainly something we had measured in the study. And in our pilot study, we had seen some improvement in peak cough flows. We lost that in the exploratory trial, the results I was discussing today. But certainly very important and something we're going to hopefully continue to look at.
Question?
Okay, question from the audience. Nina, I see a question over here.
Couple of so many questions. I don't even know where to start. First one for Dwight. If albuterol does not change the level of glycogen, how do you explain any improvement? Does it mean that it has an effect apart from the increase in the whole purpose is to increase mono-6-phosphate receptor, to increase trafficking of the enzyme. So if glycogen doesn't change, so perhaps some additional effect of albuterol.
Right. So probably it's good to.
And along the same lines, what you've shown was that without albuterol, there is no changes essentially. So which means that the enzyme doesn't work at all. Without
a little perspective. So I think the last thing you were saying is I showed a graph that showed high glycogen in mouse muscle after a month of ERT, and then we add clenbuterol and the glycogen drops quite low.
Right.
Is that
so
figure?
which means
yeah, and so what I didn't show is the untreated mouse, and there was already some decrease, especially in diaphragm and
but
heart.
But in those conditions, there is absolutely no effect of ART, right?
No, that's not true. So I didn't show you the bars actually. So there was some effect of ERT, and then adding the drugs a further effect. So that's, and we know well from mouse studies, if we simply give ERT for a month, it doesn't have much effect in skeletal muscle, but then adding the beta-2 agonist, really further lowered the glycogen. But to the point about albuterol and glycogen content, it's a small study, and in all of our studies from mice to the clinical trial, there's not as great of effect with albuterol as clenbuterol. So in the mice, we saw some decrease in glycogen when we added albuterol. So I would suspect that we are treating Pompe disease more effectively, and there is some increased GAA. If we enrolled 100 patients and very precisely measured muscle glycogen, it would be down a little bit. So I would say, and just reaching from the mouse experiments all the way to the clinical trial, I think, yes, it's working, but not as well as clenbuterol. And then the other thing is that even in Duchenne, albuterol did strengthen patients, and there are other muscle effects. Muscles are bigger, and in some studies, stronger, just giving albuterol. So that's okay, and that could be part of the benefit.
SMA2.
One more quick question for Mark.
Yeah.
Mark, you said that all those supplements and exercise increase autophagy, which I'm not sure is such a good idea in Pompe. But when you say increase in autophagy, do you really mean increase in the number of autophagosome, or somehow, for whatever reason, there is an increased autophagic flux? And for this, you would need then to increase the number of lysosomes. So what's the mechanism for that?
It's hard to know what the mechanism is specifically, but we were using just P62, which is extremely high in the mice, showing that went more towards normal when they were exercising. So certainly when you look at mitophagy, I mean, one of the things that we've seen is that the mitochondria actually seem to be upregulated at the protein level in Pompe mice, and we've seen that in our patients as well, but the actual function is not as high. So we think that the oxidative modification, the proteins just aren't working as well. The same thing is true of ryanodine receptor, for example, which releases calcium and causes contraction. There's a lot of evidence that the oxidative stress is damaging that. And it's 10,000-foot view, but that these proteins are dysfunctional, and that that by improving autophagy, removing some of the damaged proteins in mitochondria, is improving function. Turning over the cell, it's like pruning the tree, for example, in the spring. Certainly with aging, we see that with mitochondria, where we've mapped this out much better with the mitophagy.
Just be more careful about just saying increase in autophagy.
Right, of course, yeah. Semantically, yes.
Yeah, okay. There's a question over here.
Dr. Bach, you mentioned a pneumo belt. Can you talk more about that?
Yes, it was in my presentation, but I guess I never got to it. Yeah, really what a pneumo belt is, it was on the market until about 15 years ago, and now there's 2 companies in Italy that make them, and there's a company in Minnesota that makes a mechanical pneumo belt. What a pneumo belt is a girdle with an air bladder inside it. It goes under the clothing, so nobody knows you're using a ventilator. The bladder is connected to the ventilator on the back of the wheelchair. So in other words, the tubing from the ventilator goes under the clothing into the bladder on the belly. It pushes against the belly, moves the diaphragm, and ventilates the lungs, and it's very effective. Very cosmetic. In 1990, I brought a man who had been using one for 38 years to a pulmonary conference in Toronto. I said he had 0 vital capacity for 38 years, and he's 24-hour respirator dependent. Not a single pulmonologist could figure out what he was doing. So it's extremely cosmetic. You have nothing in your nose, the mouth, or your neck, and people do like it. And it can give you a liter of air, or even more, per breath. So I'm glad it's coming back. There are 2 companies in Italy that are making them, but it's not through the FDA. And there's a man who, I published a paper with this man, a mechanical pneumo belt, no ventilator, a 1-pound motor that moves the baffle against the belly and moves the diaphragm and ventilates the lungs. And he has a patent on that, and hopefully that'll be, in fact, I'm talking to a company about getting them to help him produce it next week. But it's great for people who don't want to be seen to be using a ventilator, to have anything else in their noses, their mouths, or their necks.
Okay, thank you. Is there another question? I see a question over here, over there. Yeah?
I have a question for Dr. Cobrel. I spoke to my neurologist back home about using clenbuterol with our son with infantile, and he said that through his research, the side effects were really adverse. Are you guys planning on doing any trials for clenbuterol with infantile Pompe patients, or is it strictly for adults?
The next study we've planned and have approval to go ahead, but we need funding, is a bigger study in adults. But I think that a pediatric study would be really important, and we should be very sure about the safety and benefits in adults first. And so I think there is some maybe misinformation or confusion about the potential risks, because really the notoriety about clenbuterol is that it's abused by many bodybuilders, and it's abused to make their muscles bulky. But actually there's not much in the literature about poisoning. There's one case, an extreme case of someone who took far too much that I could find.
And then I just have one more other thing. In regards to getting an MRI diaphragm screen, as well as like checking the cough flow and things like that when they're supine, would you guys think that's good to get a baseline for something like that with your child early on in infantile Pompe? Just a diaphragm study and...
You need a vital capacity. You don't need to do an MRI. The vital capacity is good enough. Or even maximum inspiratory pressures at the mouth. That'll tell you how strong the muscle is and how functional it is. You don't need an MRI.
Okay.
May I say something about it, because I showed an MRI? Indeed, FVC is sufficient to measure your vital capacity, but MRI in supine position can help you to show whether the diaphragm is earlier involved, and for example, that you already measure a decrease in FVC. But to do an MRI in supine position, then you have to have residual muscle capacity to do an FVC or a pulmonary spirometry in supine position.
Or use a ventilator while you're doing it. You can use the ventilator while you're doing the MRI supine.
Yeah, but then you don't see the movement of the diaphragm. You're influencing.
Yeah, but if you have the vital capacity and the maximum inspiratory pressures, you know exactly the state of the diaphragm. Why do you have to see it?
Because we want to see whether there is any movement and whether the movement of the spontaneous movement of the diaphragm is influenced. But maybe that's another topic, and I would like to go back to the discussion here. Yeah. Priya.
So I actually had a quick follow-up question to what Nina asked.
Can you come up maybe here to do that question over here? Yeah.
Oh,
Here. Yeah? You can keep it for the next question. Thank you.
So my quick question was also measuring glycogen content. We know that in adults, the glycogen content is not that high, and it's also so variable based on the site of biopsy. And so for our clinical trial endpoints or for realization of a benefit, my question is, we should be using other mechanisms in addition to glycogen, which I think is supportive, but in some situations may not be informative because of the variability. So Dwight, do you have any thoughts on that? At this time, but it may not be completely informative, isn't it?
So actually, that's a great point, and actually the validated endpoints that FDA asks for are not glycogen content, but 6-minute walk test, FVC, and then maybe there could be some others that are more related to muscle function. And I think in the clinical trial with clenbuterol, it was such a strong effect we could see it, but otherwise there'd be too much variability, say in the albuterol study, to see the decrease.
Correct. And I think I just wanted to make a quick comment because it was on the clenbuterol in infants. I think the other caution is because of the cardiac side effects of beta-2 agonists, and therefore safety really needs to be looked at carefully before we consider it in pediatrics where we have cardiac conduction challenges.
Okay, thank you, Priya. Is there another question?
Hi, I'm returning a bit back to the diaphragm issue. What I'm particularly interested in is the phrenic nerve. If the phrenic nerve has been damaged, what has that effect on the diaphragm and ability to breathe, please?
The phrenic nerve is not damaged. It's the muscle that's infiltrated with glycogen, but
I'm not necessarily talking within pump, excuse me, Dr. Bach, but if the phrenic nerve was damaged by another occurrence,
well,
how would
possible,
that?
Yeah. Look, non-invasive ventilation is a great solution, non-invasive ventilatory support, even for people with bilateral phrenic paralysis. You know, when they were doing a lot of these cabbage procedures, coronary artery, bypass surgery, and all of that, they would freeze the phrenic nerves bilaterally. And then they would discover that the patient couldn't breathe lying down, so they would trach them. And I've had patients die from complications of the trach tube, which again, they never needed in the first place. They could have simply used non-invasive ventilatory support when they were lying down. Phrenic nerves can be totally wiped out. You can still breathe on your own when you're erect, but you cannot breathe when you're supine. But you can use non-invasive ventilatory support when you're supine. So that's the thing about the phrenic nerves. But of course, the phrenic nerves are not really involved in Pompe's disease.
Okay, I might take this discussion a little further in private then. Thank you.
Oh, okay. Yeah.
Is there still another question? I see a question over there.
Yeah, mine's more of a, my experience with keto diet than actual question. I had a 10-month period between diagnosis and starting treatment where I was on a keto diet. 10 years prior to my diagnosis, I had sleepiness. 5 years prior, I had fatigue set on. 2 years prior, I had the mobility issues with the waddle, also trouble climbing stairs. Since I've been on the keto diet without treatment for the 10 months, my waddle's gone. I no longer have fatigue. I no longer have sleepiness. I won't fall asleep mid-conversation. And that was purely from the keto diet and a few supplements and just a lifestyle sort of change with diet. I just wanted to, tell everyone my experience. It wasn't really a question.
Is there anybody who wants
to
respond? Mark, maybe?
Yeah. I think the problem is, as you pointed out, there was more than just the ketogenic diet. My only point here is mechanistically, I thought it was going to be very effective, but we were surprised that it wasn't. So my point is we need to do preclinical studies. We need to do careful human studies because so many things can change in a single individual, changes in your diet, changes in your exercise, and so many factors. So in order to really determine the efficacy and the safety of something, we need to do things very carefully, and that would be the only point I would make. Certainly, when we look at every study we've done about 10 studies with a high-fat diet or ketogenic diet, we do see the changes in the liver. In the short term, there may be some benefits, but in the long term, we just have to be careful because fatty liver disease is thought to be the hepatitis C of the 21st century because with obesity running at about 50% in some states, with fatty liver over a very long period of time can lead to not just non-alcoholic fatty liver disease, but actually cirrhosis. So just a word of caution. But the other issue too, I would say, is that no two people respond the same way to any intervention. So anything that we say with exercise, nutrition, or a drug, there are responders and non-responders, and there's many epigenetic and genetic factors that go into this. So all we're really providing is our best estimate based on preclinical and hopefully good clinical trials as time goes forward. So I hope that this original work will lead to more work in the animals to understand the mechanism more, and of course to human studies as time goes on.
Okay.
Could I have a,
yeah,
could I have a
of
follow-up?
course. You can also.
So I wanted to ask Mark, and what's your best estimate of the mechanism for exercise improving the response to ERT?
I think that essentially with exercise, there's several things. One, we know that antioxidant enzymes upregulate manganese sod, catalase, et cetera, so we reduce oxidative stress, and we know that oxidative stress can affect, as I was mentioning before, the release of calcium from the ryanodine receptor, which will impair contraction, especially at lower frequencies. It's difficult to measure, but my thought process, based on what we know in mitochondrial protein turnover, is that the contractile proteins are similarly being damaged, and over a long period of time, the activation of autophagy and other factors in the muscle are going to remove some of the damaged proteins so that when the cell turns over, you have less damaged proteins. So the contractile efficiency, excitation contraction coupling is going to be improved. And of course, our work with aging clearly shows that with exercise, we force the mitochondria, at least the ones that are dysfunctional, have altered mitochondrial membrane potential through mitophagy, allowing the mitochondrial reticulum to grow and essentially select for the best mitochondria. I make it analogous to in the spring when you go out and cut off the bad parts of your rose bushes, it grows better, and it's very similar to what we see. So I think there's multiple things that exercise does that are beneficial. What we do not see in any of our studies is a reduction in either total glycogen or membrane-bound glycogen, which isn't surprising because with exercise, if we take a sedentary person and we train them for 4 months, we'll get about a 70% increase in muscle glycogen in those individuals. So, and I think, Nina, you did some work with the PGC1 alpha overexpression or some model similar to that, which is a form of exercise mimetic, and the glycogen levels were a bit higher, if I recall. And the same is true of humans. So I don't think the glycogen per se really has anything to do with it. So we're definitely not clearing more glycogen. In fact, we might even bring it up a little bit. But I think it's all those other factors that are having an effect. And this is why at the end of the day, exercise, people don't like to study it because it's quote unquote dirty, but it's the dirtiness of it, i.e. the multiple things that it does, which is why it works so well, I think. And it's difficult to mimic either with a drug or with a nutrient.
Okay, thank you very much, Mark. I would like to end the discussion here, and I would like to thank all the speakers, give them a round of applause, and the discussion can be continued during the coffee.